Hi, this is Sunil Mankad from Mayo Clinic in Rochester, representing the American Society of Echo Board Review. And unfortunately, due to COVID-19, we've been unable to do a live meeting this year, but we are recording our presentations and hopefully will help you in your upcoming board exams or just general review. This afternoon, I'm going to be speaking on the evaluation of the aortic prosthesis over the next 25 to 30 minutes. And I have no disclosures. I like this quote. It's from a cardiologist in the 1960s. He goes, "I was attending an annual meeting of the American Heart Association in California, and a patient who had received the Hufnagel artificial valve was being questioned. Shown here is the Hufnagel valve. It's a plexiglass cage, essentially the first ball and cage valve. And the patient was asked a question by the member of the audience if the heart sounds bothered him, because the Hufnagel valve was rather loud. He initially replied no. Then after a second he thought, he said, well, occasionally they do. I like to play poker, and when I get an unusually good hand, the sounds get louder and faster and gives me away. So one of the first ball and cage valves shown there. Now, our objectives today are to understand the critical steps for evaluating an aortic prosthetic valve with both echocardiography, including 2D, as well as Doppler echocardiography. And then we want to recognize and define the key algorithms necessary to assess aortic prostheses and understand the pitfalls associated with certain measurements. And we'll go through this in a case-based fashion. I want to keep in mind that this very important document that Dr. Zogby is the first author on from the American Society of Echo, our recommendations for evaluation of prosthetic valves with echo and Doppler ultrasound is still really one of our pivotal documents. Dr. Wiseman is, of course, our senior author on the paper, but it really is an incredible reference, and I will be referring to it throughout this presentation. Just to show you some of the valves and what they look like, I think is very important, because if we don't know what they look like in real life, we won't know what they look like on echocardiography. So here we see the Starr-Edwards ball and cage valve. These are all mechanical prostheses. Then there was the single tilting disc valves, such as the Bjork-Shiley or the Medtronic Hall. And then the contemporary mechanical valves that we use now mostly are the dual leaflet or bi-leaflet mechanical prosthetic valves, the Onyx valve, the St. Jude, and the Carbometics, each with certain advantages. We have also valve conduits. Here we have a Carbometics CarboSeal Valsalva conduit and a Medtronic open pivot conduit. These are important to recognize so you know what you're looking at with echocardiography. We then have our tissue prostheses, and of course the classic Carpentier-Edwards, shown here also as a Medtronic Mosaic. These are stented valves. We have the Medtronic Freestyle and the Sorin Freedom Solo. These are all contemporary bioprosthetic valves or xenografts. And of course, they can be made into a conduit as well, such as shown there with the BioValsalva conduit. There are stentless valves as well, and they look fairly similar on echo to native valves, except they may be just a little bit of thickening in the aortic root. And of course, in our ever-growing field of interventional echocardiography, we have our two approved TAVR valves, or transcatheter aortic valve replacement valves. We have the balloon expandable SAPIEN 3 prosthesis, as shown on the left, and then the core valve, which is a self-expanding valve on the right. And we'll show some examples. I'm not going to cover in great detail TAVR, but I will show you examples of how to quantify the degree of regurgitation afterwards, and maybe a few other complications. Now, there are really 5 key steps for evaluating a prosthesis, whether it's in the aortic or mitral position. We're going to focus, of course, on the aortic position today. We need to determine the prosthesis type and size, measure and record all pertinent 2D and Doppler-derived variables, and we'll go over that. Interrogate the prosthesis with continuous wave Doppler, and very importantly, from multiple acoustic windows to make sure that we're getting the highest gradient and velocities. Review the 2D and Doppler echo findings in toto, and if there are discrepancies, try to explain them. And then don't be fooled by a prosthesis that just has a normal gradient. Go through the process of calculating the effective orifice area and looking at certain ratios, as we'll go over here in the next 25, 30 minutes. Now, why is it important to determine the prosthesis size? Well, several reasons. Number one, the hemodynamic profiles differ according to the type of prosthesis and the size. We're going to go over a topic called prosthesis patient mismatch. And it's more common with smaller prostheses, so you need to know the size of the prosthesis that you're imaging. And keep in mind, it is prosthesis patient mismatch. It's the prosthesis that's mismatched, not the patient. We shouldn't blame the patient and call it patient prosthesis mismatch. It's really the prosthesis that is mismatched. And then we'll cover the topic of pressure recovery and why it's more common in smaller prostheses, and especially mechanical prostheses that are small. Now, here is a list of the essential Doppler-derived variables that we need to measure by echocardiography. We need to look at the peak velocity and the mean gradient, and they're really related. More importantly, we need to look at these time intervals. We'll cover the topic of acceleration time and look at the jet contour. We'll look at the ratio of the acceleration time to something called the ejection time. And these timing intervals are really crucial to understand why a prosthetic valve gradient may be elevated. We have to actually calculate the effective orifice area, not just assume what it is based on the valve size. We then index it to the patient's size. We look at the dimensionless index, also called the DI or the DVI, and we'll show you how you utilize that. And then, of course, as always with any prosthetic valve, we need to see if we can document if there is significant regurgitation present, whether it's valvular or prosthetic or periprosthetic. Now, it's really important that we look at multiple Doppler angles when we're assessing an aortic prosthesis. Shown here is the aortic prosthesis, and here we see the apical view. And in fact, in a Mayo Clinic series, that is the most common area that we look and get the largest gradient. It is indeed the apical region. But there are a significant percentage of times that the right parasternal or even a suprasternal notch gives us the highest gradient. Perhaps not as much as native aortic valve stenosis, but even with prosthetic valves in the aortic position, it's very important we measure multiple different Doppler angles and choose the best and highest gradient. Now, if a gradient is elevated on an aortic prosthesis, in other words, the peak velocity is elevated or the mean gradient is elevated, it can really be one of four abnormalities. It can be a pathologic obstruction from either thrombus, pannus, combination thereof, or sometimes leaflet degeneration can lead to obstruction. There can be functional obstruction, and we'll talk about these topics, pressure recovery and prosthetic patient mismatch. There can be significant regurgitation, both prosthetic and periprosthetic, that can lead to an elevated gradient. And it can be a high flow state, or the prosthesis may be small in a hyperdynamic situation, and it may be a normal situation. So let's take a case and go through the different ways that we can differentiate the cause of an elevated gradient. This is a 58-year-old woman who now presents with progressive dyspnea. She is NYHA functional class 3. She has a history of rheumatic heart disease, and in 2008 had a Medtronic Mosaic or bioprosthetic 21 millimeter aortic valve replacement. At that time, she also had a mitral valve repair. Now she presents 3 years later after the initial operation with profound dyspnea. We should mention that she is significantly obese with a BMI of 34. And here's her transthoracic echo. So we start in the upper left-hand panel, parasternal long axis view. We're not seeing the leaflets too clearly here of the aortic bioprosthesis. We see that the left ventricular contractility is pretty good. We see that the mitral valve repair is not too bad, maybe mild to moderate, at the very most mitral regurgitation. We see mild aortic regurgitation that's present, but we're just still not seeing those leaflets too well. Here we're zoomed in a parasternal long axis view of the aortic bioprosthesis. Remember, a 21 millimeter bioprosthesis. And here in short axis. But once again, we're not clearly seeing the leaflets, and that's very important to understand. But when we measure the gradient, it's significantly elevated. We can see here in the apical view, we got a mean gradient of 43 millimeters of mercury. And in the right parasternal, and remember, it's very important to use multiple Doppler angles and multiple imaging angles to get the highest gradient, we have a mean gradient of 56. So are these abnormal? They seem abnormal, certainly. And the differential now going through our mind is, why is this gradient elevated? Could this be prosthesis patient mismatch, or PPM? Could there be true obstruction? Is this actually just a normal function for this prosthesis? It's just a small valve. Could there be something called pressure recovery? Well, the simple truth is, at this point, we cannot tell. We need more information. So we can look up the normal valve-specific parameters for this particular bioprosthetic valve. And this is found, there's a variety of different sources. I mentioned that incredible article, first author of Dr. Zogby and Jace, September 2009. And we look here at our particular prosthesis, the Medtronic Mosaic, and we see that our size prosthesis, 21, which is a smaller prosthesis, the typical mean gradient is 14 plus or minus 5, with an effective orifice area of 1.4 plus or minus 0.4. But certainly our mean gradient in the apical view of 43, or in the right parasternal view of 56, is significantly higher than this predicted mean gradient for that particular prosthetic valve. So we then have to go through our differential diagnosis as to why the gradient is indeed elevated. This is what we expected, and we got a much higher gradient than that. But the gradient will be high if there's true obstruction, prosthesis patient mismatch, a high output, or pressure recovery. So just having a high gradient doesn't separate out any of these entities. So we'll have to go further. And the first thing we'll do is start looking at the timing intervals, and two in particular. We look at the ejection time, or the time from aortic valve opening to aortic valve closure, and we look at something called the acceleration time, or the time from aortic valve opening to the peak aortic valve velocity. And we see in our particular case, in our patient, the acceleration time is 88 milliseconds. We then look at the ratio of the acceleration time to the ejection time, and we see that this value is 0.27. So then we start thinking in our mind. Here we have our acceleration time of 88 milliseconds and the ratio of the acceleration time to the ejection time of 0.27. So what do these timing intervals mean? Is this consistent with obstruction? Is this a normal prosthesis? Or do you really have no idea? Well, that's what we're going to go through. This is important work that came from Texas Methodist Hospital, once again from the group of Dr. Zogby and Quinones, and they see very clearly that the acceleration time cutoff of 100 is pretty good for determining abnormal valve function. In other words, if this acceleration time, or the time to peak velocity, is more than 100 milliseconds, and 100 milliseconds is a number that you can remember, and I think that the board exam would ask you to remember it. If it's greater than 100, that's abnormal, and it suggests obstruction with pretty good sensitivity and specificity. If you look at that ratio, And now this is a number that you probably got to look up. You can't really remember it too easily, but 0.37, now we're really very sensitive and remaining quite specific at determining abnormal function. So if that ratio is higher than 0.37, we probably have a problem with obstruction. Now, the cause of that obstruction would still need to be determined, but we definitely would have stenosis of that bioprosthetic or prosthetic valve. But our patient, as you recall, had an acceleration time of only 88 milliseconds. So the really is not consistent with obstruction or a stenosis. And the ratio was 0.27. So once again, that's not consistent with obstruction or a stenosis. So just by looking at these timing intervals, we've essentially excluded true obstruction of this bioprosthetic valve. Now, we never saw the leaflets well, but because the contour of that velocity Doppler tracing was such that the time to peak was only 88 milliseconds, or the acceleration time, and the ratio of the acceleration time to the ejection time was only 0.27, we have essentially excluded obstruction of that bioprosthetic valve. Now, there are many reasons that you could get obstruction. So let's say that we had an acceleration time more than 100 milliseconds. All of these things have to be in our differential. This could be endocarditis. There could be a true thrombosis, bioprosthetic valve thrombus. It just could be wear and tear of the bioprosthetic valve, and eventually it's worn out or not opening well, and there could be a high gradient, or it could be leaking and there's a high gradient. It could become calcified over time, often with abnormal calcium metabolism, and there could be pannus. So pannus versus thrombus is something that we need to help differentiate by echocardiography. So this is not our patient. We've essentially excluded obstruction because the acceleration time was only 88 milliseconds. But this is a different patient, and let's take a look here. This was a 69-year-old who had a tissue prosthesis, same size as our patient, and we can see a little turbulent color Doppler flow. We see this little bit of a mobile echo bright echo density here, very echo bright, just on the LV outflow tract of the bioprosthetic aortic valve. Here's a zoomed in view. Once again, the leaflets look like they're moving okay, but there's this very echo bright echo density, high acoustic density mass. We go to our apical long axis view, and once again, we see this mobile echo density here, just on the LV outflow tract side of the bioprosthetic valve. And we see turbulent color Doppler flow across the bioprosthesis. And when we measure the gradient, we're getting a mean gradient of 70 millimeters of mercury. Once again, clearly abnormal. But we never really saw the leaflets that well, so we do a TEE, and here's a long axis view. And once again, note this echo bright mobile echo density on the LV outflow tract side of the prosthesis. Here in short axis, we don't see that echo density too well, but we do see that the leaflets of the bioprosthetic valve are moving pretty well. So it doesn't seem to be a leaflet problem per se. Here we have a long axis view. It's akin to a parasternal long axis view, and now zoomed in, we really see this very echo bright echo density on the LV outflow tract side of the bioprosthesis, and very severe turbulence of color Doppler flow is noted. Here's just a deep transgastric view. Once again, look at this mobile echo density that's present right there where the yellow arrow is. And it's very bright from an echo standpoint, meaning it's echo bright, high acoustic density. And here's the measurement of it as shown here in the right-hand panel. Well, this patient went to the OR, mean gradient was 70 with that abnormal echocardiogram, and they found significant pannus formation along the valve cusps, circumferentially sparing the leaflet tips. The leaflet tips are moving okay. So this is a case of an overexuberant inflammatory reaction or healing process that led to pannus on this bioprosthetic valve. So this is indeed pannus formation. And the very echo bright nature was really the key. Now, it's tough, and you really can't 100% say sometimes whether it's true thrombus or pannus. But in general, thrombus has a higher gradient, and pannus has a more dense or echo bright or increased ultrasound video intensity ratio, meaning it's more echo bright, as in our case. But it can be difficult. Thrombus usually is attached to the occluder or the leaflet. They both can be mobile. Oftentimes, thrombus is more mobile. So here we see an example on the left-hand panel of a bioprosthetic aortic valve with thrombus. Note how now the leaflets are thickened. They have this globular, thickened appearance with reduced mobility. Clearly, they're not thin, mobile leaflets. Very, very thickened and reduced mobility. In comparison to just a degenerated bioprosthetic aortic valve on the right-hand panel, where it's more echo bright. The leaflets are a little bit thickened and restricted in mobility. But this is a softer acoustic signature, and you'd have to be worried about thrombus. It can be difficult to tell the difference between the two sometimes, and sometimes you just have to try and treat with anticoagulation and try and figure out if it is a thrombus versus just a degenerated leaflet or pannus. But the timing of when the valve prosthesis fails can be helpful. This is data from my friend Alexander Egby and Heidi Connolly and Soren Pislarou from our institution. And they looked at a large series of around 400 patients. And clearly structural failure for all the different prosthetic locations, but especially the aortic, occurred later than bioprosthetic valve thrombus. But bioprosthetic valve thrombus did not just occur in the first few months. And that's generally the time that we keep people on anticoagulation with warfarin. But it turns out that the highest incidence occurred really at about 2 years. But clearly, it occurred earlier when there's thrombus involved compared to structural failure. So one of the ways you can differentiate the two, in addition to leaflet failure and pannus generally being a little more echo bright and having a higher acoustic density, is when the bioprosthetic valve fails. If it fails many years after implantation, it's a much higher likelihood of leaflet degeneration or pannus compared to thrombus. Now, this is an unfortunate case just to show you of a patient that underwent TAVR as part of the partner study, but unfortunately developed an acute thrombus. So here we have the left atrium, left ventricle. Here's the implanted TAVR valve. And here, this very large mobile echo density. This occurred during the procedure. The patient had some type of hypercoagulable state, and you can see that it's growing here. Here, just in 1 hour after the initial presentation, you can see how big the thrombus is. And now the thrombus actually prolapses across the mitral valve into the left atrium. And unfortunately, this was a cohort B patient who was not deemed to be a surgical candidate. And unfortunately, he did not make it. And here we can see the acute thrombus that occurred. So thrombus can occur with these TAVR valves, and we're learning more and more about it. This is a paper written by a group of investigators on the Portico valve, which was a type of percutaneous aortic valve, TAVR valve, published in 2015. And they used CT scan to detect the thrombus, and it was very good. What they noticed is that the thrombus occurred much more when you only got dual antiplatelet therapy compared to warfarin. And there were more strokes in the people that had a thrombus as well. And here you can see that CT imaging can be very good to detect bioprosthetic valve thrombus. We're still trying to define the ideal anticoagulation regimen and duration. Different institutions do different things. But nonetheless, with TAVR valves, be on the lookout for bioprosthetic valve thrombus. You can sometimes detect it with echo, but CT scan is very good as well. Here we can see that the two cusps here are not moving at all. We can see that they're thickened here on the CT imaging. All right, let's get back to our case. So just to remind us, the patient had a mean gradient over 50. She's symptomatic with heart failure, a valve that was put in just 3 years earlier, 21 millimeter Medtronic Mosaic. Here now, we finally get to see the leaflets. Because remember, on the transthoracic echo, we did not see the leaflets very well. Here on TE now, we see the leaflets pretty good. And they're moving pretty good. And remember, we essentially excluded obstruction because our acceleration time was only 88 milliseconds and the acceleration time to ejection time ratio was 0.27. And that would fit that our leaflets are moving pretty good. Now, it's important to always calculate the effective orifice area. Not just assume based on the size of the valve, but to actually make the measurements and calculate the LV outflow tract area, the TVI by pulse Doppler in the LV outflow tract, and then divide it by the TVI of the prosthesis by CW. And that will give us the effective orifice area. You have to actually make the measurement of the LV outflow tract. It can be difficult, but you need to try and actually measure this effective orifice area. Don't just assume based on the size of the prosthesis that that's the LV outflow tract diameter. It can still be quite variable, and it's important to actually make this measurement. It's also important to where you measure the pulse Doppler in the LV outflow tract. You do not, as in the lower panel here, want to be in the zone of flow convergence or the yellow area. You want to be in the blue, outside the zone of flow convergence. This is the true pulse Doppler, or to be used in the stroke volume calculation, not in that zone of flow convergence. You need to back out away from that zone of flow convergence, or you'll overestimate the effective orifice area. Now, there is a term that you'll hear called the dimensionless index, and that can help assess prosthetic aortic valve function. It's also a short nickname of the DVI or DI, and it's essentially the ratio of that pulse Doppler in the LV outflow tract. And remember, we're backing it away from that zone of flow convergence where there's more laminar flow. That ratio of that pulse Doppler over the CW across the aortic prosthesis. Normally, that should be greater than or equal to 0.3. And that dimensionless index is a good way to start as well to know if there's a problem with this bioprosthetic valve or any prosthetic valve. So here we have the complete measurements in our patient, okay? The gradient was high, but the acceleration time and the ratio of the acceleration time to ejection time did not suggest obstruction. In fact, essentially excluded obstruction. Leaflet mobility was normal. So once again, we still haven't really decided what's going on here, but we know it's not obstruction. We then calculate the effective orifice area, and then we can look at the dimensionless index. And in our patient, if it's normal, it helps suggest that it's one of these two entities. Now, very importantly is, did the effective orifice area and gradient or dimensionless index change over time? So you would not expect it to change over time if it was prosthesis patient mismatch. That should be abnormal right away, as the same for pressure recovery. If there has developed an obstruction, the gradient should increase over time. The dimensionless index should get worse. So in our patient, here we have our dimensionless index, and it came out at 0.28. So kind of borderline, but not definitively abnormal. The calculated effective orifice area is 0.97 centimeters squared, with an indexed effective orifice area of 0.57. So that's abnormal. But we took our patient to the cath lab and actually measured the gradient. And it turns out that the mean gradient in the cath lab with Millar catheters was only 26 millimeters of mercury. Whereas the Doppler gradient that we calculated in the echo lab was in the 50 millimeter of mercury range. Why this significant discrepancy? Well, there's something I didn't tell you. I hid it from you, and that was the size of the ascending aorta. And our patient had a rather small ascending aorta. At the sinotubular junction, it only measured 2.1 centimeters in diameter. When you have a small ascending aorta diameter, you're especially prone to something called pressure recovery. And that's exactly what was occurring in our patient. We excluded obstruction by looking at those timing intervals. We then saw that the gradient was falsely elevated, overestimated by Doppler echocardiography, and we saw that the aorta was very small. A concept first really described by the group in Vienna. There's a nice review article here by a good friend of ours, Ramdas Pai. And essentially, this idea of pressure recovery is that as flow accelerates towards a stenotic aortic valve or aortic prosthesis, there's a convergence of flow streams that results in flow acceleration and corresponding pressure drop by the Bernoulli equation. And that creates a vena contracta. As the flow accelerates, the kinetic energy increases and the pressure or potential energy drops. This creates a somewhat false or overestimation of the true vena contracta or Doppler pressure gradient. So that's what pressure recovery is. You can correct for it. There are formulas. This is Dr. Philip Peebrow's classic paper calculating the energy loss index, and another paper from our own journal, JACE, also showing us that you can calculate based on the ascending aortic area. In other words, smaller ascending aortas will have more significant pressure recovery. Calculated aortic valve area or effective orifice area, and divide it by that ascending aortic area minus the aortic valve area by Doppler. We don't routinely do this, but if you have a small aorta, I would recommend that you consider it, or a small mechanical prosthesis in the aortic position that's giving you a high gradient. It may be because of this pressure recovery phenomenon. When does pressure recovery occur? When is it especially relevant? Well, when there's a tubular aortic stenosis, doming of the aortic valve, a small ascending aorta, meaning less than 3 centimeters at the sinotubular ridge, a narrow LV outflow tract diameter, and in particular with our topic today, when there's a small mechanical bileaflet prosthesis. And that's especially true if our CW goes right through the middle of that bioprosthetic mechanical prosthesis. And here is data just showing you that when the aorta is smaller, there's a greater degree of pressure recovery. So the bigger the aorta, the less apt it's going to cause significant pressure recovery. The smaller the aorta, you're going to get a Doppler gradient that's significantly higher than the cath gradient. That's because we overestimate the true gradient because there is pressure recovery. Now, the other entity that we have to consider is something called prosthesis-patient mismatch. And remember, it's not the patient's fault, so we don't want to call it patient-prosthesis mismatch. The mismatch is in the prosthesis. It can be considered to be present when the effective prosthetic heart valve area after insertion into the patient is less than that of a human heart valve. All prosthetic heart valves are smaller than normal and inherently, therefore, have some degree of prosthesis-patient mismatch. If it's less than 0.65 centimeters squared per meter squared, that's suggestive of severe prosthesis-patient mismatch. Now, it can be difficult to differentiate between pressure recovery and prosthesis patient mismatch. Sometimes you don't know for sure which is playing a greater role, and that's where the hemodynamic cath can be very helpful. Is it important? Yeah, if you have severe prosthesis patient mismatch, the majority or predominance of data that we have available to us suggests that your outcome, including from freedom from CV death in this study, is significantly worse than if you have no or moderate prosthesis patient mismatch. That's especially true if you have LV systolic dysfunction. But it is important. It is a concept that we need to understand. The one thing that you must also remember is this would be abnormal soon after implantation, and you would have a higher gradient because of it, and a reduced calculated effective orifice area. Now, I wanted to show a few things about TAVR, and for the purposes of the boards, it's very important that we be able to quantify the severity of periprosthetic regurgitation. Periprosthetic regurgitation occurs more often when there's a large aortic annulus, an undersized prosthesis, asymmetric cusp calcification, significant LV outflow tract calcification, a prominent septal bulge, or we didn't put the valve in the right spot. It's too low. So here's a question, and once again, as this is a recorded session, it'll just really be a rhetoric question, but here we see a TAVR valve that's just been implanted. In this case, it was in the early days and we did TEE. Most of the time now, well above 90% of the time, we just do transthoracic, but we can see that there's a periprosthetic leak. Here it is in long axis view, left atrium, left ventricle. Here's our TAVI valve. And then here, very importantly, the short axis view. And that short axis view is really one of the keys. And when we look at it here in short axis, we're fairly confident that this is moderate periprosthetic regurgitation. Now, the valves are getting so much better. In the third generation valves, it's rare that you see too much periprosthetic leak. Nevertheless, we need to understand and know the definitions of how we define that. And the Valve Academic Research Consortium 2, or VARC2 group, has developed a consensus document. And if that circumference of that periprosthetic leak is less than 10%, we define it as mild. Initially, the group suggested that if it was 10 to 20%, it was moderate, and more than 20% was severe. But they've revised that, and now severe is considered if that circumference area or perimeter that the periprosthetic valve leak occupies is more than 30%, it's considered severe periprosthetic regurgitation. So know that definition for the purposes of your board exam. Comprehensive evaluation is always looking at the DVI first. And if it's abnormal, I don't know what's going on there. If it's abnormal, meaning that it's greater than 100, the acceleration time is greater than 100, and the DVI is abnormal, it suggests aortic stenosis. If the acceleration time is low, make sure your measurement was accurate because there's a little bit of discrepancy. If the DVI is kind of in the moderate range, meaning in between abnormal and normal, once again, those timing intervals are really critical. If that acceleration time is more than 100 milliseconds, it does suggest significant obstruction. If it's less than 100, now we got to look at the effective orifice index and consider prosthesis patient mismatch or a high flow situation. If in fact there's greater than 100 milliseconds for the acceleration time, thrombosis, stenosis, some type of obstruction is probably occurring. Now, my colleague, Dr. Blauet, has published beautifully on this, and rather than jumping to the dimensionless index right away, she suggests looking at the acceleration time. And if it's greater than 100, and your calculated index effective orifice area is less than 0.65, and your gradient is up, there is pathologic obstruction. The gradient may be low, but there still is obstruction because it's a low flow situation. But this acceleration time being elevated and a small effective orifice area is really the key. If, on the other hand, your acceleration time is normal, less than 100, it's pretty unlikely that you have significant obstruction. If you have a small indexed orifice area, it could be prosthesis-patient mismatch plus or minus pressure recovery, especially with smaller prostheses. If, on the other hand, your calculated effective orifice area is normal, now you're really talking about a high flow state, or there could be pathologic regurgitation. The numbers for a tissue valve are a little different, and I put this in your handout for completeness. Keep in mind that when you have a small aorta at the sinotubular ridge, you're much more apt to have significant pressure recovery. So with that, I close this session. We are putting together a question and answer board review type session that will occur later this year. And I'm certainly available to be contacted at the above noted contact information, my email, if you have any specific questions. Thank you very much for your time and consideration. And I've also included in your handout this very beautiful paper by Lori Blauett and Fletcher Miller. And it goes through how to define significant regurgitation in a very algorithm-based format. And I'll close with this quote from Enrico Fermi. Before I came here, I was confused about this subject. Having listened to your lecture, I'm still confused, but on a higher level. But hopefully in reviewing this data, you'll be able to do well on your board exam or recertification, or just in daily clinical practice. Thank you very much for your time.